This conference will now be recorded.
Thank you so much, Laura, and I want to thank everybody for being here this evening. My name is Anna. I am at the Hopewell branch of the Mercer County Library System. Before we get started tonight, I do want to let you know of a couple other virtual programs that are coming up this month. Tomorrow night, we actually have a program at 6 in the evening, Quilting Through the Centuries, Women's Life and History in America. And that will be presented by Hannah Gaston, who is the coordinator of school programs at Keene University's Liberty Hall Museum. And again, that is tomorrow night, Thursday the 9th at 6 o'clock. And then on Monday, the 13th at 7 o'clock, we have Christmas and the Winter Solstice. And that will be presented by Jeff Kampf from Lifelong Cognition. And you can find these programs and more on our website, www.mcl.org. And I do want to remind everybody about our app that we have that you can download to your smartphone or your tablet, and that's My MCLSNJ. And you can find out about those programs and much more that's happening at the library. Now let's get to why we're here this evening. Again, I want to thank everybody for coming out this evening. Tonight, we will be talking about side effects of cancer therapies, and we will be hearing from Doctors Amjad and Pancari from the Astera Cancer Care. Astera Cancer Care. They will be addressing the toxicities and side effects of cancer therapies, including chemotherapy, hormonal therapy, immunotherapy, target treatments, and oral cancer drugs. So we hope that you gain some information this evening. And if questions do come up while they are talking, as was mentioned earlier, we do invite you to type those questions into the chat box, and we will address those at the end. So I will relay those questions to the presenters, and they will field those questions. So without further ado, I pass it off to our presenters.
Good evening, everyone. I am Dr. Maqsood Amjad. I'm a medical oncologist and hematologist with Astera Cancer Care. Astera Cancer Care is a large private enterprise. We are spread in the Central Jersey area and also North Jersey. And we treat a variety of cancer diseases, including cancers, blood diseases, and also help in the non-oncologic infusions at our centers. Dr. Philip Pancari is my colleague. He will be also part of the presentation and will be presenting portion of the presentation in the later part of the hour. I'm very excited and thankful and appreciate you all joining us today, and that shows your enthusiasm for learning. The side effects of chemotherapy is a vast topic, and it's hard to do a justice within an hour, but we'll try to do our best and try to bring the salient features and main points of these side effects. Now, before we go into that, I think it's important for us to learn some historical aspects of the cancer. Cancer fight is going on for centuries. In the ancient times, cancer was treated with burning the cancer with the metal rods, and then it transformed slowly, gradually into better surgeries, taking the portion of the cancer out, although very crude. And then today, as you can see, we are much better equipped with the modern treatments, including advances in the surgery, in radiation and chemotherapy drugs. Now, the chemotherapy drugs are not something which was prevalent in the past. It's a recent history. The first chemotherapy drug was actually created in the beginning of the last century, around 1920. And it was not created to treat cancers or any diseases. Actually, it was created as a warfare. Nitrogen musters were compounds which was used in the Second World War. And what was noticed was that these cancer drugs were causing lowering of the blood counts. And based on that, that findings, the two pharmacologists at that time they started experimenting on this drug called mustine, which was part of this group of compounds. The first study was published, paper was published in 1946, showing that when these drugs were injected into a person with the cancer, it was lymphoma, which they chose to treat as a first cancer, and the lymphoma started decreasing in size. So with that findings, then it was used in more cancer patients. In about 1950s, the second group of drug called anti-metabolites, where the folic acid metabolism is disturbed by those drugs, were looked at, and again, the cancer reduction effect was seen, and that's how the first few drugs came into being, and the combination of those drugs were used in cancer. And today, since the late 1990s, there is a flood of these medications in the market, and we have hundreds of medications. I always, when talking to the trainees in medical sciences, when I talk about the cancer drugs, I tell them that we used to be able to remember on our fingertips how many drugs are there and what their side effects are, and how they are used, each and everything about those drugs. But today, there are hundreds of drugs, and we have to refer to those drugs time to time. Now, the cancer treatment drugs are divided mainly into conventional chemotherapy drugs, which are the historically used for almost a century. Hormonal drugs are also something not new. They have been used for many years in treatment of breast cancer and prostate cancer. And then the newer drugs, the targeted treatments, are mainly divided into large molecules and small molecules. The large molecules are mostly monoclonal antibodies. If someone has any experience, as know some of the family members, a lot of these monoclonal antibodies are used in the treatment of lymphomas and leukemias, such as rituximab. The small molecules are mostly in the form of oral drugs, pills, and they work on specific targets, in the cancer genesis, and try to inhibit those mechanisms to make the tumor shrink. And then we have immunotherapy drugs, which basically enhance your own immune system to fight against the cancer cells. And then less commonly used gene therapy and vaccine therapy, which are still in the experimental phases, although there are now and then there are few advances, but still it's not something commonly used. Now, it's important to understand that the normal cells and cancer cells are different in many ways, but I want to emphasize on three main properties, and that is that cancer cells divide rapidly and do not die, as compared to normal cells, which on regular basis divide in a specific way based on some signals by the body that when to divide and when to stop, and they have a programmed death pathway where at certain point they die. The cancer cells are also different than normal cells because they don't follow any rules. Normal cells, I mentioned, follow some rules when to divide, when to stop. But these cells, because they develop a lot of mutations, and they are not under the control of the body mechanisms. And then these cells tend to invade and spread to other areas, as compared to normal cells, which divide in their areas and stay there and are part of certain organ system. Also want to quickly go over, you don't have to, I don't want to overwhelm you with the diagram and details, but what I wanted to show was that normal cells, when get the signal, that cells, along with the sum of the parts, such as centromere and mitochondria, they all slowly divide into two equal portions, and eventually even the chromosomes divide and share one chromosome from each side and make two similar kind of cells, and that's the normal kind of duplication of cells. Now, in the next slide, when I bring it, I'm going to show you that these drugs work at different levels, and I'll show that first. At different levels, And basically, they may stop the replication of DNA. They may stop the production of the newer cells, like by inhibiting or not letting uncoil the DNA, which is in the spiral form. So at different levels, these drugs interact, with the division of the cells and stop it from growing. The main classes of these drugs are alkylating agents, which one of them we discussed earlier, nitrogen mustards. They interact with the DNA bases, breaks or prevent their replication, and that's how they stop the growth of the cells. Antimetabolites, they inhibit enzyme production, which is needed for the DNA or RNA synthesis. And there are cytotoxic antibiotics, which also bind to the DNA and unwinds the DNA helix, that spiral DNA, which we all know as a symbol also, and that inhibits the DNA and RNA synthesis. And then there are platinum agents, which again, they work on DNA. They are a class of microtubular inhibitors, which binds the microtubules and disrupt the mitotic spindle. And then there are topoisomerase inhibitors, which again inhibit an enzyme which helps to separate the DNA strands for copying. It inhibits that so the cell cannot divide. And remember, the difference also is that the cancer cells, when it cannot divide, it dies. However, the normal cells, when they have a programmed death pathway, they die and new cells keep getting back into the organs. So here is a list of some of the common side effects. Some of them we are going to go over in detail, but I just want to go over some of the concepts. So the cells which are rapidly dividing, they are the main target for the chemotherapy drugs, and cancer cells are one of the rapidly dividing cells. However, there are many other cells, such as the lining of the gastrointestinal tract, the hair, and the blood cells. These all cells divide rapidly, and they are affected when the cancer cells are affected by the chemotherapy. Normal cells also affect. However, after that effect is over, the normal cell will again divide and become normal. However, cancer cells will die and will be eliminated. So leukopenia is a term when the white cell count is low. As I mentioned, that the chemotherapy drugs work on the bone marrow, which is the factory to manufacture the blood cells, and these are rapidly dividing cells which are always being manufactured. So it does cause leukopenia, lower white cell count, anemia, low hemoglobin, red cells, thrombocytopenia, low platelets, and all these conditions has specific purpose. So white cells, help you in fighting infections. So when they're low, people at risk of infections. The hemoglobin gives you energy and provide oxygen to all cells of the body. And if you are anemic or your hemoglobin is low, you feel weak, tired. If the platelets are low, which are the cells which help you to stop bleeding, and if they're low, your risk of bleeding goes up. The lining of the mouth or even the whole gastrointestinal tract, your gut, are also rapidly dividing cells. When it affects the mouth, you get mouth sores, you get altered taste. When the lining of the lower part of the gut is affected, you get diarrhea. You get nausea and vomiting because of that altered taste and mucositis and some other mechanism which affect the central, centers in the brain. Hair loss, also called alopecia. People can get fever, especially when their white cell count is down. The risk of infection goes up, and they can get fever, which becomes an emergency, medical emergency when white cell count is low and you get fever. There can be infertility issue with many of the chemotherapy drugs. Fatigue is one of the most common side effects. People don't feel good, especially a few days after the chemotherapy. The chemotherapy can affect the nerves, especially the small nerves, and that damage can lead to either feeling of numbness and tingling, or even advanced stages, painful neuropathy. Drugs can cause constipation, but many times constipation can be a phenomenon of the cancer itself or due to the pain medication people take for cancer. And sometimes it's hard to differentiate that is due to which reason. Some drugs can cause fluid retention. Also, there's increased risk of blood clots, leg swelling can happen due to decreased appetite, diarrhea. Patients can get dehydrated. Patient also can get something called chemo brain or fogginess, which can affect memory and thinking process. And then, of course, chemo can damage any organ of the body, including kidneys, liver. It can affect the sexual health. It can affect the skin in terms of rashes, especially some of the drugs are more common to cause rashes. In particular, the newer oral targeted therapies are common to cause rashes. And some drugs, such as some of the cytotoxic antibiotics like anthracycline or adriamycin, commonly used in breast cancer and lymphomas, can weaken your heart muscle and the pumping power of the heart. So this is like a broad overview of multiple side effects which can happen. I'm going to focus more on some common issues seen in the cancer patients. The chemo-induced nausea and vomiting, also labeled as CINV, can be of different kind. The acute nausea happens within 24 hours of chemotherapy. The delayed nausea happens after 24 hours and can stay up to 72 hours or even longer sometimes. And a term is used, breakthrough nausea vomiting, which occurs about 5 days after the chemotherapy, and that's after you have done the optimal treatment for the nausea vomiting, and still some patients will break through that. That's why it's called breakthrough nausea vomiting. Refractory nausea vomiting is a term used when, in spite of your best treatment, you still have nausea vomiting, which is relatively rare in today's time. And then anticipatory nausea is something which is not due to chemotherapy, but is triggered by the sensory stimuli like anxiety, and it happened even before starting the chemotherapy. So these terminologies are useful in devising the treatment of the nausea and vomiting. There are some treatment-related factors. For example, certain chemo agents are more emetogenic or cause more nausea and vomiting. It depends on the dosing and schedule of the chemotherapy agents. It also depends on the understanding of the healthcare professionals, how much they experience they are they following the guidelines which are to best minimize the nausea and vomiting, and also differences in different antiemetic drugs available based on the insurance clearance and approvals. There are also patient-dependent risk factors, such as nausea is more common in females, in women. People between ages of 6 to 50 years are more likely to experience nausea vomiting. Alcohol consumption is inversely related. People who have no alcohol intake, they have more chances that they may feel nauseous. The history of inner ear disease, such as vertigo, can put patients at risk of having more nausea and vomiting. High levels of anxiety can contribute. Women who have history of sickness during the pregnancy, or patients who have motion sickness history, they are more prone to get nausea and vomiting. And of course, dietary differences can also play a role. Again, this diagram is not to overwhelm you, but if you look at the the gut lumen, which is in the pink and purple, here the chemotherapy affects some receptors and cells, and then which secrete some chemicals. Serotonin is one of them. These chemicals are then the message is taken by the vagal afferent nerves to the brain eventually, and some of the substances are produced at the deeper level, and those also can affect the area which is responsible for the vomiting center in the medulla. And so this is a complex mechanism where there's a direct effect and there is a central effect. And of course, when we're devising these antiemetic therapies, we're trying to block this effect at different levels to see how we can best control the chemo-induced nausea and vomiting. In cancer treatments, we use grades for almost all toxicities, and it helps us to figure out what's the best way to treat that patient is. So in nausea and vomiting, the loss of appetite without any alteration in eating habits, or just one episode of vomiting in 24 hours is considered a mild grade 1 side effects. Grade 2 nausea is that when oral intake is decreased without any significant weight loss or dehydration or malnutrition, and IV fluids are not, not really indicated within 24 hours. Vomiting of 2 to 5 episodes in 24 hours is also taken as grade 3. So grade 1 and grade 2. Grade 1 and grade 2 are in general considered mild toxicity, and grade 3 and grade 4 are considered severe toxicities. And grade 5 is always in all the side effects is death, which is not something common thing to happen. But in a neglected patient, these things can lead to death due to severe dehydration, electrolyte imbalances when someone doesn't seek help for a long time and does not bring it into medical attention. The grade 3 is where it starts now. You need the IV fluids. You may need intravenous nutrition, and your episodes of vomiting are more than 6 in 24 hours. And grade 4 is when it causes life-threatening consequences. That becomes grade 4. So in many cases, grade 4 in general mean that you may have to take patients off treatment or make significant changes in those treatments. Grade 3 in general, you may have to cut down the dose of the medications and be very, very cautious and vigilant with the next treatment. Grade 1 and 2 needs minor interventions such as improving the antiemetic or anti-nausea regimens and keeping patients well hydrated. So the management of nausea, vomiting, we talked about briefly. Patients are advised in advance to keep themselves well hydrated when they're being treated with these chemotherapy drugs. The nausea medications are used as a prophylaxis in almost all the patients. They are usually sent home even if they don't have nausea with anti-nausea medications in case they need them. Certain high emetogenic regimens where we think that these regimens will definitely cause nausea, we use pre-medications ahead of time to prevent that nausea vomiting. Sometimes we use things like lorazepam or Ativan as an anxiolytic to cut down the anticipatory nausea. Patients are advised to keep themselves well hydration, ginger ale helps, relaxation techniques, hypnosis, acupuncture in refractory cases, keeping antacids like Tums, Rolaids. These things help to counteract the nausea and vomiting. So nausea and vomiting, although is one of the dreaded side effects and most common, but in today's time with the modern drugs available to counteract the nausea vomiting, even the drugs which help in the delayed nausea and vomiting, and they work in different levels in that whole cascade of the cycle which causes nausea and vomiting. This is a rare kind of phenomenon now, that when patients have refractory or breakthrough nausea and vomiting, so most of the patients in general these symptoms are well controlled and are not a problem in general. Next, I'm going to talk about the neutropenia and neutropenic fever. When the when the cell counts drop down to certain levels, again, there's a grading system, and I'm going to just concentrate on the last row, which is leukopenia, actually the third last row where neutropenia is written. When the neutrophils go below 500, that's grade 4 toxicity. And those patients are at very high risk of getting infections. So any patient who has neutropenia uh, in the grade 2, grade 3, grade 4 area, and they have fever, that's considered oncologic emergency. And patients are advised, always educated and advised to go to the emergency room right away so that they can be given intravenous antibiotics, because the fever may not be due to infection, but it's always taken as if it is due to infection because of the significant mortality rate if we don't treat those patients with the intravenous antibiotics and don't help to treat them in a supervised and a monitored kind of environment. There are chemo regimen which, as an oncologist, we know which can definitely will cause the neutropenia, and there are some which may not cause. So based on those criterias, we, in anticipation, as a prophylaxis, we introduce growth factor therapy, which is called in the old days, it used to be injections used to be given for 7 to 10 days after each chemo cycle. And then we came up with the pegylated form or a long-acting form called Neulasta. And now there are many biosimilars or generic preparations also available. I like this graph because you can see the gray shaded area. That's a patient who did not have a Neupogen or growth factor therapy after the chemotherapy. And what you see is the duration of neutropenia is long, and the days, which patient has neutropenia are also expanded. So more prolonged the neutropenia is, more chances that that patient may get infection and can get into a catastrophe. And if you give the Neupogen or Neulasta in today's time, you reduce that duration of neutropenia, and that help patient not to get into a prolonged period where they can get infections. So the risk of infections is significantly reduced by using the growth factors, and that has become a standard of care in most of the chemotherapy regimens. Here you can see, I just want to bring it that gray is where we have not used the Neupogen and or Neulasta or growth factors. And if we look at that, there's a 93% reduction in neutropenia-related hospitalizations and 94% reduction in the febrile neutropenia. So all this translates into not only saving the patient life, reducing the hospital visits, it also translates into significant saving of the resources and capital. When patients are neutropenic, we tell them they should wash their hands frequently. They should avoid crowds and sick people. They should avoid fresh fruits and vegetables because they are exposed to the nature. They may have bacteria on their surface, which can be ingested and cause problems. We want them to avoid contact with fresh flowers and plants for the same reason. We like them to keep a good oral hygiene, avoid deodorant so that your pores or skin pores are not clogged. These patients, are advised to monitor for any temperatures greater than 100.5 or other signs of infection such as chills. Any white patches in the mouth, which are in fact the fungal infections or yeast infections. We like them to watch for any redness, swelling, pain in ear, eyes, skin, rectal area, which again, meaning a skin infection. And then we want them to watch for diarrhea, any dysuria or burning urine, cough, any significant rusty or greenish phlegm or shortness of breath. Again, signs that someone may be developing pneumonia or urinary tract infection or gastroenteritis. Next, the diarrhea. Diarrhea is again a common side effect of chemotherapies, and in particular, some of the anti-metabolites, 5-FU and capecitabine, irinotecan, Taxol. These are the common chemotherapy drugs used mostly in colon cancer, lung cancer, breast cancer, and these can cause significant diarrhea. And then there are targeted treatments, which are mostly tyrosine kinase inhibitors used in lung cancer, renal cancer, liver cancer, and many other types of cancers, and they have diarrhea as the common side effect. I put the, again, grading here, and if we just concentrate on the diarrhea grading, less than 4 stools per day is above the baseline is grade 1, and when they increase to 6 or 4 stools in 24 hours, that becomes grade 2. Increase 7 stools per 24 hours over baseline, or incontinence, or need for IV fluids, or hospitalization, this is all considered grade 3, and then grade 4 is life-threatening. We ask patients to always to keep the Imodium at home, and sometimes we have to give them prescription antidiarrheal medications. They are advised to keep well hydrated. Use of Pedialyte, Gatorade, which has electrolytes in it, helps to avoid any significant deficiencies of electrolytes. Avoiding milk products help them to slow down the diarrhea. Avoiding alcohol, coffee, high-fat diets, these all help in those circumstances. So sometimes if the diarrhea is not controlled with the common antidiarrheal medication, patient needs to be brought into the office or hospital to hydrate them frequently and supplement them with the lost electrolytes. Some drugs like octreotide sometimes is used when it's refractory and it happens after each chemotherapy. This helps in the secretory type of diarrhea. And some patients can also develop infectious diarrhea due to Clostridium difficile toxin, and they are treated with antibiotics such as metronidazole and vancomycin. Moving on to peripheral neuropathy, I want to keep a tab on the time also. The prior exposure to neurotoxic agents, patients with history of diabetes mellitus, with vitamin deficiencies, history of paraproteinemia, which are plasma cell diseases, which affects the kidneys and bones, thyroid dysfunction, alcohol abuse, pre-existing neuropathy, kidney dysfunction, patients with HIV disease. These are all risk factors for patients to develop neuropathy more commonly than others due to chemotherapy drugs. The main drugs which causes the neuropathy, the most commonly known drugs are Taxol, Taxotere, and oxaliplatin, cisplatin and vincristine. These are also common drugs to cause that. And then some of the newer drugs, which are many of them are used in the treatment of multiple myeloma, such as bortezomib and thalidomide. These also cause significant neuropathy. One of the peculiar drug, oxaliplatin, is unique in that actually in the very beginning, when it came out, it was very strange phenomenon for many of us, that patients become sensitive to cold. Like moment after receiving the chemotherapy drug, if they're exposed to any cold objects, such as holding a can of soda, they will feel the numbness and tingling. Sometimes even to the extent that if they inhale in a cold weather outside, where they can inhale the cold wind, they have a feeling of like they have stopped breathing. In fact, they haven't, but it's just that their nerves get affected in that way. So cold sensitivity is very peculiar to oxaliplatin, and it persists for 72 hours around that time, and then it goes away. And in general, it's not very debilitating or cause significant problem. The other type of neuropathy which lingers and to become permanent is a quite a nuisance and significantly affect quality of life in some patients. So the main things again this is the grading. You can look at that, concentrate on the neuropathy sensory, which is more common. So the best intervention is that if patient ever start having early signs of neuropathy, we like to know that, because we want to cut down and dose adjust their chemo medications to prevent further worsening. In some cases where it's severe, we may have to give them a break or stop the drug permanently, because there's nothing more worse than having a debilitated patient who may have been who is receiving a curative regimen. There are many drugs which has been used with partial success in treating the peripheral neuropathy. Some of them are anticonvulsant agents, some are antidepressant agents, and sometimes patients get this fear of what kind of drugs are being used to treat this kind of side effects. So they need education about that. These drugs help, especially the painful neuropathy, when you always have a feeling of pain in your toes or in your fingers. Sometimes we have to use opioids, the medicinal marijuana, and some derivatives like Marinol help. In some refractory cases, the acupuncture is needed, and many other ancillary treatments, such as applying ketamine or capsaicin cream or lidocaine on those areas, use of ginkgo biloba, which is a herbal medication, and glutamine, and then sometimes electric shock therapy is used, in those areas to counteract this. Chemo-induced alopecia, also called CIA, or in layman term hair loss. This is common with some of the drugs in the anthracycline class. One of them is adriamycin, used in breast cancer, in lymphomas and leukemias, and they almost always cause hair loss. Taxanes also are drugs which high percentage of people will get hair loss. Etoposide, tocoisomerase drugs are called topotecan and irinotecan, and cyclophosphamide. There are many other drugs which will cause, but these are the main ones. The useful hints are, we educate patients to use, gentle hair care, use of soft brush, less frequent washes, gentle shampooing, avoiding extreme temperatures. And if they have significant fall, they can shave their heads so it's not a nuisance. They, hair fall on every place. And there are some, wigs and scarves can be used. There are analogous wigs where you take your patient's hair and put them on the prosthesis, and that can be applied to the head, which gives a more natural look. And then cooling caps. Now, cooling caps is a concept which actually came from some experiments in rats, where they use epinephrine and lidocaine on their areas after giving them, and then give them some of the chemo drug, and they found that some of the hair in those areas were sustained. And the concept behind is to cause a vasoconstriction, like, decrease the supply of the blood in those areas, so the chemo does not go into the hair follicles, and their metabolism is slowed down, and which helps to preserve those hair. The caps can be rented, which by the patients. They bring those caps to the treatment areas. These caps are kept in freezers, and patients have to wear them 30 minutes before, during, and 90 minutes after the chemotherapy. These caps, have to be changed frequently, and they are rented like on monthly basis. And I have seen patients using that, but more common these days is more sophisticated form of cool caps, which is where a machine do the job of freezing, and I think insurance are almost now looking into approving for payment also, but they are available at a cost, couple of $1,000 through the whole treatment. And this machine delivers a coolant throughout the cap, keeping the cap at a constant temperature, usually is 22 degrees centigrade, and these gaps are used before, during, and after. And there has been about 50 to 75% decrease risk of hair loss, and they are quite helpful. I'm quickly going to talk about hormonal treatment. Some cancers are hormone sensitive. Some of them are listed here: the breast cancer, ovarian cancer, endometrial, prostate cancer. Breast cancer, when the cancer cells have estrogen uh, estrogen receptors on their surface, those are the cancers which can be treated with the anti-estrogen treatment. So there are two main groups here. Tamoxifen, basically it binds to those receptors, and then the estrogen is not available to the cancer cells, which used as a feed for the cancer cells, and that's how it shows its effect. And there's significant armamentarium in the treatment of estrogen positive breast cancer. Aromatase inhibitors basically is used in the postmenopausal women, and they basically inhibit or block the synthesis of the estrogen. And these drugs, anastrozole, also called Arimidex, letrozole, Femara, and exemestane, aromasin, these are commonly used in breast cancer. Fulvestrant is intramuscular injection, and this also falls in the anti-estrogen group, like tamoxifen. So these are the common drugs. Some of these estrogen drugs are used in ovarian and endometrial specific types of cancer, but use is relatively rare. And then prostate cancer, where the testosterone hormone is the feed for the prostate cancer cells. These hormone treatments are geared towards blocking the testosterone in different ways, like Lupron will affect on the luteinizing hormone, affects the which is in the brain, which then affects the synthesis of testosterone. And there are other next generation drugs which similarly block the testosterone, depriving the prostate cancer cells of the testosterone, and affects the growth of the cancer cells. The main side effects, which are as compared to chemotherapy, they are very mild, relatively mild. Hot flashes are similar as if women go through menopause. That can be debilitating in some patients, and then we use certain medications, duloxetine and other antidepressant medications which work for these hot flashes. Aches and pains are common, especially with the aromatase inhibitors, and sometimes can be debilitating. Fatigue is common but tolerable. Patients can show emotional lability who are on these hormonal drugs. And then hair thinning can happen, but not hair loss, and that's not common. Some patients can gain weight. It can affect the bone health, cause weakening of the bone, like osteopenia and osteoporosis, especially aromatase inhibitors. And sometimes we treat patients with the anti-osteoporosis medications to counteract that. And last two side effects are extremely uncommon, less than 1%, but I mentioned them because they are important. The drugs like tamoxifen and aromatase inhibitors can cause blood clots. So we always teach patients that in case they get leg swelling or pain, they need to contact their physician to make sure there's no blood clot. And then very, very low risk of endometrial cancer. And it manifests with abnormal female bleeding, which is easily detectable. So it always can be caught in a very, very early stage. And really, I'm not aware of any fatal outcomes ever from this kind of endometrial cancer. All right, so I am done with my portion. I'm going to hand over to Dr. Pancari. He's my colleague, and we both work together at our Robbinsville office. And he's going to share his screen.
Thank you, Dr. Amjad. So, My name is Dr. Philip Pancari. Are you guys actually seeing my whole screen, or are you only seeing the presentation part?
We're seeing the presentation.
You're only seeing the presentation. Okay, good. Okay. So yeah, I'm Philip Pancari. I work with Dr. Amjad with Astera Cancer Care. I'm also a hematologist and oncologist. I'm going to talk about immunotherapy and the side effects associated with immunotherapy. It is very much increasingly a topic for oncology. The way that oncology has trended in general has been further and further away from the standard cytotoxic chemotherapies and a little bit more toward immunotherapy, especially more in recent years. There's certainly still a definite important role for both. But immunotherapy has been, especially over the past 5 or 6 years, has been a very active topic. And I think these are important side effects to discuss. I think everybody is sort of familiar with stories of people getting chemotherapy and the things that they've gone through, as well described by Dr. Amjad. I think here, maybe some of the side effects of immunotherapy are a little bit less well known. So I'm going to start by talking a little bit about what immunotherapy is, the mechanism behind how immunotherapy works, because I think it's important to know that in order to really understand why the side effects are what they are. So briefly, I'll discuss how the immune system relates to cancer development and how it fights cancer, specifically how it's designed to recognize cancer, particularly in its early stages, but also later, and how it's involved in trying to fight it, including the types of cells and the mechanisms it uses to try and fight it. Then we'll talk for a moment about the types of strategies that tumor cells will use to try and evade the immune system, to try and sort of prevent its destruction by the immune system, and sort of the creative measures by which it succeeds in doing that oftentimes. And then the main portion to be discussed is, what can we do to maximize or augment the immune system's attempt at killing the cancer, either eradicating it or controlling it. And the therapeutic approaches, as detailed there, the one I'm going to focus on very largely is checkpoint inhibitor immunotherapy, because that is sort of far and away the most common thing that we've been using. So a little bit about the immune surveillance mechanism. The immune system, everybody thinks of the immune system as fighting infections, and that's certainly a large part of it. But the immune system is also integral in preventing the development of cancers. It's thought that many cancers sort of begin attempting to develop, and if everything is working ideally, they should sort of be snuffed out by the immune system at an early stage. Even after cancer does begin to develop, there's sort of a push and pull with the immune system, which is trying to fight it. As I think touched on by Dr. Amjad, when cancer develops, it's very largely a result of either damage to the DNA structure of the cell that's then passed on to the progeny of that cell, or it's sort of just an error in the division. When a cell divides, when one cell divides into 2 daughter cells, it has to copy this very complicated molecule, this very complicated double strand of DNA, and it has to do it perfectly. And it's incredibly complex, and there are mistakes. And even after mistakes in that complex copying process, there is a sort of an adjacent complex mechanism to try and repair the mistakes that every cell has. And it's only when the cell sort of also fails at repairing that mistake that the immune system, is sort of, ideally it would step up and sort of take care of the cells which were then dysfunctional and sort of get rid of them, because if that doesn't happen, they pass on that mistake to every other cell in the lineage. And if you get enough of those mistakes, or one at a particularly crucial area of the DNA, what ends up happening is a cancer develops. So what specifically can the immune system do to try and either stop a cancer in the early stages or sort of push it back if it's already developed, to sort of have this tug of war with it to try and fight it. I'm just mentioning the few main cells here that are involved. T lymphocytes are, if you've heard of lymphocytes, there are B and T lymphocytes. The T lymphocytes, and specifically the CD8 positive ones, are called cytotoxic cells, T cells. They specifically bind to tumor cells and they kill them. It's a very complex mechanism, but at its most basic level, that's what happens. Natural killer cells, we call them NK cells, also do a similar thing. They don't have a specific a mechanism for choosing what type of cancer cell they bind to, and they don't need quite as much specific stimulation, but they do a very similar thing. And you could sort of see pictures here that I've put that are kind of amazing electron microscopic pictures of how these lymphocytes and NK cells will sort of team up against a tumor cell. You could see in the lower left, there's that yellow tumor cell, and these are immune cells sort of binding to it to wipe it out. And then macrophages are kind of a support cell. You can see one on the right there, and they basically secrete chemicals. And the point of those chemicals that we call cytokines is to recruit other immune cells and sort of bring them all to the area to say, hey, there's something to fight here. So how does the cancer manage to develop despite this complex and amazing mechanism by which the immune system is fighting against it? Well, it turns out tumor cells are pretty tricky themselves. One thing which actually becomes really relevant when you start talking about how immune therapy works is that the immune system needs, T cells, NK cells, they need indicators on the proteins on the surface of the tumor cell that make the tumor cell identifiable. And they also need things on the surface of the tumor cell that are kind of handholds that can be sort of bound to so that the cell can then be killed. So one tricky thing that tumor cells will do is actually hide those proteins, hide those targets, those markers from the cell surface so that the immune system can't recognize them. The other thing it can do, I mentioned macrophages secrete these chemicals to recruit other immune cells. Well, tumor cells secrete their own chemicals to try and calm down the immune response. The tumor cells can express proteins that sort of promote growth. So in that case, instead of hiding from the immune system, what they're doing is sort of saying, well, we're just going to ramp up the production and the division of our cells, in which case we may be able to sort of overcome the immune system response just by sheer volume and rate of growth. So that's the other thing it can do. And I've bolded this final thing at the bottom because it's the most relevant thing, to the main type of immune agent we're using called checkpoint inhibitors. And what tumor cells will do is they will express a protein called PD-L1, which is a receptor on its surface. And what that does is it's really very, it's sort of very tricky. It will bind to T cells and other immune cells and turn them off. It will sort of put them in, this is an oversimplification, but it will basically render them inactive or put them into a sort of hibernation state with this PD-L1 molecule. So what are the types of immunotherapies? I just listed the 4 of them here, real briefly 3 of them, and then one is the one I'm focusing on for the remaining slides. So cytokines are the oldest approach. Cytokines, you'll recall, are just chemicals that are secreted to activate the immune cells, primarily the lymphocytes, which directly kill the tumor cells. So, IL-2, interleukin-2 is sort of the one that everybody knows and the one that's been used for years. Cytokines are rarely used now. This is used here today basically for advanced kidney cancer in a very select population. But they basically give this IL-2 and it sort of ramps up the whole immune response to this incredible degree and activates tumor cells, activates T cells in a manner that's pretty non-specific. It just makes them all sort of become very activated and more ready to kill tumor cells. We don't use that much anymore. The second one is the one that I think is most important now. CTLA-4 inhibitors I won't get into, but it's a very similar concept. The ones that we talk about often and we use every day in clinic are checkpoint inhibitor immunotherapy drugs. And those are your drugs like pembrolizumab, atezolizumab, nivolumab, drugs like that. This is a newer approach. These drugs were in clinical trials, 7-8 years ago, and they started to all be approved, I would say probably 5-6 years ago. They're approved for many different types of cancer. Still predominantly, they're approved for cancer which is sort of incurable and it's sort of gotten away, from its starting point, and it's used in later lines of therapy, but it's moving closer and closer to something that we use up front. So we're using it very often and in earlier lines of therapy. And what it does effectively is it binds to that PD-L1 molecule that puts the T cells into hibernation. So the tumor cells are unable to put the immune cells into hibernation because the surface protein they used to do it is being blocked. So it's really very complex, and it's a great therapeutic option. It's very promising, and it's really become very helpful. The third thing is sort of T cell manipulation therapies. I really won't get into that except to say that CAR T therapy, of which you might have heard, is sort of the main and most exciting example of T cell based therapies. And what that does is recognize that these T cell lymphocytes are involved in killing tumor cells, but in cases where the tumor's sort of gotten out of control, clearly the T cells just aren't recognizing it enough or aggressively killing it enough. So what they're doing here is removing the patient's T cells from the body. They're inserting a gene into the T cell's DNA, cloning that T cell, so then you have a bunch of T cells that have been genetically modified, and then reinfuse them into the body. And once you reinfuse them into the body, it's like having a dog with a scent. It knows what to attack, and it goes after the tumor cells very quickly. And finally, there's vaccine therapy. I won't get much into that. Those are effectively vaccines that are they're basically taking viruses and engineering them to attack tumor cells. It's used in melanoma. There aren't a lot of approved practical applications for that, but it is something that is in a lot of clinical trials. So side effects of immunotherapy, what we set out to really talk about here. The side effect profile of immunotherapy is really, as I mentioned at the beginning, it's a lot different than chemotherapy. Chemotherapy, I think the most concise summary of the difference is that chemotherapy is sort of, as Dr. Amjad said, killing rapidly dividing cells, and in doing so, it kills some normal cells too, and it sort of is overall a immune suppressant. It's sort of, in order to kill tumor cells, sort of a necessary consequence is it's also suppressing the immune system typically. Immunotherapy, on the other hand, ramps up the immune system. It finds a way to harness the power of the immune system and to make it more efficient and more aggressive and more effective. That does not mean that the side effects of immunotherapy are something we don't have to worry about. They are, on average, different. I don't think people find them on average as worrisome. It's kind of easy to talk to patients about immunotherapy as if it's going to be easier in a sense, but that's not always true, and there are side effects that really need to be monitored and watched for. A couple of quick points about things that I'm not focusing on primarily. I mentioned cytokine therapy, where they inject IL-2 back in, a couple of decades ago when this was a bigger thing than it is now. Cytokine therapy, where they just push, IL-2, this chemical, into patients' bodies to rev up their immune system so non-specifically, the body can even act like it has a severe infection at times, almost like a septic response, on account of the immune system being so activated. And that's why we don't use this all that often, at least not the IL-2 form of it, because it's sort of kind of, it can be very dangerous. It can almost look like a patient is septic with a severe infection because of how activated the immune system is. The vaccine therapies, many of them are mainly in clinical trials, but as you might expect, they cause sort of a flu-like syndrome on average. You might see fatigue, you might see muscle aching, you might see low-grade fevers. But the main thing I'll talk about for the remainder of the couple slides here is what do the checkpoint inhibitor immunotherapies do? Drugs like pembrolizumab, drugs like nivolumab. So I've divided these into systemic side effects, which essentially mean it affects the whole body. Skin and mucosa, which is like, obviously skin, and then within the mouth and lips and things like that. And then the GI system, the gastroenterologic system. There's a little bit more on a subsequent slide. But with regard to systemic side effects, fatigue is reported pretty often in patients on PD-L1 inhibitors, which I'm using interchangeably with checkpoint inhibitors. So when I say those two things, they mean the same thing. Fatigue is, the numbers we have, the percentages I've put here really come from how often they're reported in the setting of clinical trials where the drugs were first studied. It's a little tough to suss out fatigue as a consequence of a drug specifically, because so much goes into fatigue, and these are patients who have an illness and are stressed out about the illness and are going back and forth with a sort of busy schedule with treatment. So, immunotherapy does make patients tired. The quoted number here is 43%, but it seems to be less substantial than the more aggressive chemotherapy regimens on average. Patients are typically able to have enough energy to go about their lives when they're on this treatment. Infusion-related reactions, by that I mean when the drug is literally in the process of going into the body, into the vein. Let's say the bag is hanging there and it's dripping into a port or an IV. An infusion reaction would be something that happens in that moment as the drug is moving in. It could be chills, it could be trouble breathing, it could be a rash, it could be hives, it could be the blood pressure dropping. And a lot of chemo drugs have significant risk of infusion-related reactions, and particularly a lot of these drugs we call monoclonal antibodies that we use to treat conditions like myeloma and lymphoma, things like rituximab and daratumumab. Those drugs have pronounced and severe infusion-related reactions on occasion. They're possible with PD-L1 inhibitors, but they tend to be mild. Not that they can't be severe, but they tend to be mild, and they're not that common. I mentioned cytokine release syndrome, which is sort of that septic response, which is very severe. It's really rarely reported with PD-L1 inhibitors, checkpoint inhibitors. It's much more with the CAR T-cell therapy, which I think is a little beyond the scope of this. Fever, actual fever being 100.4 in a neutropenic patient and 101 really in a patient with a normal white cell count, but about 10 to 28% of patients report fever. In my experience, they're not typically high fevers in these patients, but that they can be, they're real and patients can feel feverish. Skin, 13 to 24% of patients will get a rash. And this all makes sense intuitively, because these are all things that happen when the immune system is being activated. So rash, itching, vitiligo is a phenomenon where the immune system turns itself on the skin pigment and it attacks the skin pigment, and you get these patches of skin that are lighter than the surrounding areas, which also is intuitive because the immune system is sort of attacking things it wouldn't typically attack in these cases. I mentioned infusion-related reactions again here only because you can get hives from that. And very rarely there are these toxic skin changes that look more like burns, which are very rare with immunotherapy. But I wanted to mention it. It's not even given you can't even really find a percentage odd of it happening. And then the GI system. So I've capitalized diarrhea due to colitis because among the things we worry about in patients who are on checkpoint inhibitors, it's this phenomenon of the immune system getting carried away and attacking a part of the bowel. And when the immune system attacks the bowel, it can become very inflamed. Patients can have lots of diarrhea. And as mentioned earlier, enough diarrhea can be life-threatening. Enough diarrhea can give people severe dehydration and electrolyte changes and very low potassium and all of that, low blood pressure. So this is something that, having it happen in a severe manner is not particularly common, but it is one of the main things that we really, really look out for. Nausea it does not reach proportions it typically does with chemotherapy, with cytotoxic chemotherapy. Liver inflammation, hepatitis, it's not uncommon to see the liver enzymes go up a little when we check the liver tests in the blood, just because the immune system is sort of, doing some inflammatory things within the liver. So this is just sort of a very elementary picture of colitis, which is just, the bowel will sort of literally look like that. If you do a colonoscopy in somebody who has colitis, it will just look very red and inflamed. And a bowel like that is much more likely to not absorb the water that's passing through. So you end up with diarrhea. So there's more. The endocrine system is, you could think of that as the hormonal system. And it can really do a variety of unusual things to the endocrine system. It can cause low thyroid function, which is hypothyroidism, which is what makes people sort of very tired with dry skin, brittle hair, leg swelling, edema, things like that. Another name is Hashimoto's for that. It can cause overactive thyroid, which is hyperthyroidism, which is Graves'. The characteristic thing about that is patients' eyes get really wide because of just the hormonal effect of having such a high circulating thyroid hormone. It's common enough that in patients who are on PD-L1 inhibitors, we check thyroid labs virtually with every cycle to make sure the thyroid's not becoming under or overactive. Underactive being more common, we see that more often. And then I mentioned some really unusual things. Hypophysitis is usually, it's inflammation of the pituitary gland, adrenal insufficiency. The adrenal glands sit on top of the kidneys and they secrete cortisol. It's unusual. And then type 1 diabetes is interesting, and it makes perfect sense here. Type 1 diabetes, what people often call early onset diabetes, is really an autoimmune condition where the immune system attacks and destroys the pancreas. So theoretically, you can sort of see how it would be possible if you rev up the immune system enough that it would turn its guns on the pancreas. But it's very rare to have it happen to a degree that results in type 1 diabetes, under 1%. Sort of mirroring the concern we have about colitis is the concern we have about pneumonitis. That's sort of the other really serious thing that we don't want to miss or not treat when it needs to be treated. Pneumonitis means literally inflammation of the lungs. And it's a little bit distinct. It's actually quite distinct from a bacterial pneumonia. It may have some things in common with bacterial pneumonia. It may be trouble breathing, it might be cough. But pneumonitis tends not to be sort of a clump of bacterial infection in one spot. If you look at the lungs on a CAT scan of a patient with immune-mediated pneumonitis, you sort of see just this patchy inflammation all over throughout both lungs. And what it is just a rush of immune cells and fluid and things into the lung where it doesn't belong. And it truly is the immune system just sort of getting a little bit out of control and causing that inflammation. It doesn't happen that often. It's virtually single-digit percentage chance in patients who are treated for a prolonged period on the drug. But it is something to not miss, because at its extreme, it can be life-threatening, just like extreme diarrhea, if patients end up unable to breathe. And pneumonitis is accompanied by, it's typically a dry cough. Usually an infectious cough is a wet cough with producing sputum. Pneumonitis is usually a dry cough. It's usually some trouble breathing. It might be low-grade fevers often accompany it. So it is distinctly different from a bacterial pneumonia. And then less common things, you can get myositis and arthritis mean inflammation of the muscles and the joints, which again makes perfect sense. And it can even in severe cases resemble like a rheumatoid arthritis if you get these inflamed joints. It's not common, but you see it occasionally. Blood abnormalities, if the immune system starts to sort of turn on the bone marrow a little bit, you can develop low blood counts, anemia, things like that. Myocarditis is a severe one I've not seen personally, but it is reported. That's where the heart gets inflamed. If we see that, we stop and we don't. One is not to really go back to the drug after that in any context. So how do we treat immune-mediated toxicities of PD-L1 checkpoint inhibitors? It's not nearly as complicated on average as what Dr. Amjad described. It's almost always one answer, and it's with steroids. Steroids, as I'm sure you've heard of them, are prednisone is the oral form. Dexamethasone can be oral or intravenous. Dexamethasone tends to have a little more ability to get into the spinal fluid in the brain, but they're similar drugs. And then topical steroids like hydrocortisone that you can buy over the counter. So, you basically are making a judgment call. In mild cases where you have a rash or something that's covering a small portion of the body, you might just say, buy some hydrocortisone cream over the counter. If you have some joint aching, you might say, carefully take some of an anti-inflammatory over the counter, ibuprofen or something. But if you have moderate to severe toxicities that are immune mediated, you're typically using steroids. You're typically giving people prednisone or some equivalent. And very often, much more often than not, that works really well, because what steroids do is they make the immune system back off, and they do that very aggressively. Now, these checkpoint inhibitors were studied in patients who were on no more than 10 milligrams a day of prednisone. So one theoretical concern is, if you're giving people all of this steroid, are you stopping the checkpoint inhibitor from working? And because if the whole point of the therapy is to overactivate the immune system, and then you give something to reverse that, you're at least in theory, you have to be concerned that you are sort of preventing the response you set out to get. But you also don't want to make people prohibitively sick from the treatment. And we think that up to 10 milligrams per day of prednisone is okay, and that you probably still get a good response to the treatment despite that. At higher doses, it's unclear. And then there are severe cases of immune-mediated reactions that I won't get into in further detail, other than to say, if somebody has grade 4 diarrhea, it's life-threatening, pneumonitis to the point where they might end up on a ventilator, rare things, you might try you might try things that are potentially even considered more aggressive than steroids. You have T-cell and cyclophosphamide. You have T-cell inhibitors that are literally chemotherapy you might try because you want so badly to suppress the immune response at that point. Drugs like infliximab, which you might have heard of, which is a TNF-alpha inhibitor. So what happens if you have a patient who's had some immune toxicity when they're on this drug, but let's say it's working for them? And this is a difficult sort of weighing of risks and benefits we have to do all the time in the clinic. If a drug's working well, if the cancer is under good control because of it, we don't want to stop it if we don't have to. The patient obviously wouldn't want to stop it. If I were the patient, I wouldn't want to stop it if it's working, unless we need to. And there's no easy answer. Basically, we have to look at how severe was the adverse reaction. If it was grade 4 life-threatening, then the answer is almost always we don't try it again. If it's something like heart inflammation, we don't try it again. If somebody was in the hospital for 10 days, and got intubated or something, we would not try it again. The sort of gray area is if somebody has grade 3 diarrhea or some other grade 3 toxicity or a really bad rash, but it responds really well to steroids right away. It could maybe be considered with some sort of extra precautions, like maybe maintaining a low dose of a steroid or something like that. So we just have to use clinical judgment. It ends up being a discussion about the risks and the benefits, and really just an evaluation of how bad the reaction was and whether treatment for it worked quickly or not. And I think this is my final slide here. There are special circumstances too. The main one I encounter is, what do you do if you have a patient who you would be giving an immune checkpoint inhibitor to, or any other immunotherapy for that matter, and they have a pre-existing autoimmune or rheumatic condition? So let's say somebody has rheumatoid arthritis or Crohn's disease or ulcerative colitis or scleroderma or lupus or something like that. Those patients were excluded from all of the studies. So when these drugs were getting approved, they were approved without any eye toward, whether they, what would happen if you gave them to a patient with autoimmunity. It would seem that the obvious answer would be don't try it, because you're dealing with somebody whose immune system is already by nature overactive and attacking part of their body, and here you're revving it up more. That said, it gets tricky when you get people who come in who used to have active autoimmunity long ago, but now it's well controlled. But you have people who have very subtle autoimmunity that's not so bad. So there's very little data. It's difficult, and again, it's the type of thing that ends up being a real discussion with the patient about their risk and the benefit. And if it's tried very carefully. If patients have had a recent COVID-19 infection, this, as you might expect, falls a little bit into, or a lot into the category of we don't really know. But I just mention it because of this recognized phenomenon where some of the illness of COVID-19 comes from an exaggerated immune response to the virus, this sort of inflammatory response that causes all this inflammation, particularly in the lungs. So it's something I would probably avoid in that setting. I would probably at least wait until a patient were a considerable period of time away from that infection. But of course, there are exceptions to everything. And if a patient just tested positive and had no symptoms or very mild symptoms, I don't think it would be unreasonable to consider it in the right setting. Patients who've had a donor transplant, typically these are bone marrow transplant patients who are at risk of the new immune system attacking their body. So patients who've had a donor bone marrow transplant typically don't get these drugs, or at least we try very hard not to give them. And I just want to mention very elderly patients because this is a concern that comes up with chemo, and the trend has been very much toward looking at physiologic age rather than chronological age. So, the trend in medicine is very much to treat patients in a manner that is in accordance with how they act and feel rather than their actual technical age. But still, a lot of doctors are still, I think a little bit hesitant once patients get to a certain age to treat them as aggressively with chemo. It seems like with immune checkpoint inhibitors, patients tend to tolerate them about equally well, and they seem to be about equally effective regardless of the age of the patient. So that seems to be a lesser concern than you could maybe consider it with chemo. And that's it for what I have to say. Thank you for listening, and I'm happy to take any questions.
Thank you so much for the presentation this evening. I do want to invite those participants, if they do have questions, to go ahead and enter them into the chat box. I do have one that came in that was asking, when you were talking about developing black blotches on your fingers and your toes, we have someone who's talking about they're developing black blotches on their head. Is that something where they should see a dermatologist?
Is that directed to, is that as it relates to immune therapy?
I'm sorry, it was directed to Dr. Amjad,
okay.
please.
Okay.
Sure. So there are certain drugs which can cause skin darkening and skin pigmentation. Some of them, especially the 5-FU, which is commonly used in colon cancer and gastric cancer, capecitabine. These drugs can cause those black patches. And there's no need to go to, in general, to dermatologists. These things go away after a few months after stopping the treatment, and they start fading away, in a couple of months. So this is just, a side effect which has cosmetic value to patients, but otherwise it's not something life-threatening or nuisance in other way.
I think you had specifically said fingers and toes, but I think this is happening on the participant's head, so that can happen as well.
So I think you just have to make sure that this is the same kind of darkening or pigmentation of skin which you see with these drugs. It's not something else. You don't want to miss any melanoma kind of malignancies which are a separate kind of issue. In general, they have more raised and more light kind of appearance. But I think if there's a concern, I think there's should not be any hesitancy to see the dermatologist. But these kind of darkening of skin in general happen fingers, toes, inside the oral cavity, inside the buccal cavity.
Okay. And then someone had asked a question in the chat, and Dr. Amjad, do you mind kind of just speaking the answer that you had given? It was about the Herceptin whether Herceptin was immunotherapy, please.
Right. So question was whether Herceptin is immune therapy. So Herceptin is a more like a targeted treatment that you find out targets. HER2/neu expression of HER2/neu protein on the cancer cells is well known for a long time. And in general, this was a poor prognostic kind of feature in breast cancer. So for the longest time, it was just a prognostic feature. But then we developed a drug which in particularly blocks those cells and has shown to be significant improvement in the outcome of those cancers. So now this is a part of treatment of breast cancer where the cell expressed this particular protein called HER2/neu, or also called ERRB also. So this is a group of family proteins which are expressed on cells, and this protein is now also has been shown to be expressed in lower percentage than breast cancer in gastric cancer, in esophageal cancer, in lung cancer even. So wherever this protein is expressed in the cancer cells, those cancers can be treated with these kind of drugs, and there are many others like that.
Okay, thank you so much. I appreciate you just vocalizing that answer because some people might not have seen the answer in the chat, so thank you for that. I do not see any other questions coming through. I do want to thank Drs. Amjad and Pancari for taking time this evening, as well as Astera Cancer Care for bringing their program and their knowledge and their expertise to our community. At this time, I will thank the presenters again and thank all of you for attending this evening. And we hope to see you at other programs coming up. And thank you again, and have a good evening, everybody.